To that point, we saw CRs at a much higher clip than we saw with THP.
And we don't even expect CRs in the metastatic settings.
All right. That was a lot. Lots of stuff in the neoadjuvant adjuvant setting, but there was some other important information that came out in the metastatic setting. In particular, I'm focusing on DB09. I know it was way back at ASCO in the summer, but maybe first you can tell us a little bit about that study, how it was designed, put together, who was the target population.
Sure. So DB09 was a study looking at T-DXd with pertuzumab in the first line setting for metastatic HER2 positive breast cancer. And this is a space that's really been held by the CLEOPATRA or the taxane plus trastuzumab pertuzumab regimen for the last very many years.
Yeah, THP. Yeah.
Exactly. So this was comparing T-DXd with pertuzumab, at least this is the results we saw, T-DXd with pertuzumab compared to THP. What we haven't seen yet is the T-DXd alone arm. But it again showed superiority of T-DXd with pertuzumab to our THP regimen. I think none of us were surprised to see that result because, T-DXd has been superior to standard treatment almost in every line it's gone up against.
Pretty much everywhere you've tested it. Yeah.
But I think it does bring up some questions. One being that on this trial, patients were continued on T-DXd with pertuzumab until disease progression, whereas the CLEOPATRA patients, the patients on the THP arm treated like the CLEOPATRA regimen, could stop after, I believe, 6 cycles. They could stop the chemotherapy and then just go on to the 2 antibodies and add endocrine therapy. And we know we have other data in that space showing that a CDK4/6 with endocrine therapy after stopping the taxane did benefit a great number of patients who are HR positive and HER2 positive. So I think
so that's the Patina trial that you're referencing there.
Yes.
Yeah.
So I think again, it puts us in a good place where we have choices, but it does make our life a little bit harder.
Yeah, and so I've heard a lot of docs talk about the Patina trial. Interestingly, we've had the DB09 study, at least the portions that have been reported out, presented in the New England Journal very recently, late October, I think.
Yep.
We're still waiting on Patina. I know that paper's under review as well. But once all of that is out, once the NCCN guideline looks at all of these things and starts populating these options for us, do you think you're going to approach certain patients differently, i.e. the ER positive, HER2 positive patients differently from maybe the others, or will you have sort of a one size fits all? Like, have you thought about that yet?
I think we're going to all end up with much more individualized approaches. I think somebody who presents with metastatic disease with a very high volume of disease, maybe even CNS mets at presentation, I think that for a patient like that, it's clearly T-DXd or T-DXd plus pertuzumab would be my treatment choice. But if someone is very strongly hormone receptor positive, maybe their volume of disease is low, they are de novo, they haven't had any treatment before, it would be really nice to be able to give them 4 to 6 cycles of THP and then follow that up with endocrine therapy and palbociclib, like Patina. So I think we are going to have to make some choices and individualize it to patients, their comorbidities, their disease burdens, and frankly, what their goals and desires are.
Yeah. Do you see a world where there's hybrid approaches where you do a little bit of induction with this and then switch over to that? Yeah.
I think that's what a lot of people are going to do.
Yeah.
They're going to kind of because we're not going to have any trial like that coming out, maybe ever, certainly not.
Well, there's the European study that's going to look at that because for regulatory reasons, they need to have evidence to be able to pivot back to HP. Otherwise, they can never go back to it.
Oh, interesting.
So they're in a unique situation. So we will get data for that, but it's not, it's
not immediately.
Not immediately. Yeah. It's going to take a little bit of while.
So I think a lot of us in the HER2 positive metastatic setting are used to giving this sort of induction regimen with chemotherapy and almost even advising our patients that way, that we're going to do a certain number of cycles of this and we're going to take the chemo drug off. So just kind of push through it and then you'll go on the 2 antibodies alone and your life will be much better.
And just to play on that a little bit, with the taxane-based approach, we often don't treat to best response. We just sort of give 6 cycles, and sort of call it good or whatever. With this other drug, with T-DXd being available, do you see the same sort of paradigm? I'm just going to give X number of cycles, or I'm going to go to best response? Like, again, we're speculating.
Yeah.
You haven't done any of this.
Right. I mean, I think it's going to be a question of when we stop it.
Yeah.
Because it's such an effective drug. But, you know, if you look at any of the T-DXd in metastatic breast cancer trials, the response rates are so high.
Yeah.
So I think this is a drug that we're going to see really great responses in the metastatic setting.
Well, and to that point, we saw CRs at a much higher clip than we saw with THP.
And we don't even expect CRs in the metastatic setting. So, so I think we will probably be a little surprised when we start to use it first line, and, you know, may think about doing it to best response, and that best response may come a little earlier than we're used to.
Yeah.